the first thing you have to think about is why, right? So the underlying etiology of the high calcium is the most important thing to consider. And while in the outpatient setting, it's usually primary hyperparathyroidism, you do have to think about things like underlying malignancy and iatrogenic hypercalcemia. Once you have the diagnosis of primary hyperparathyroidism, then you're thinking about primary hyperparathyroidism and how to treat it. The only way to cure it is with surgery. Anybody with a diagnosis of primary hyperparathyroidism is a candidate for surgery. But we do think about when would surgery be most likely to help a patient. I think the easiest way to split it up is into symptomatic patients and asymptomatic patients. There are a lot of patients that may not progress over time. There are guidelines we can use for asymptomatic patients. I think the 5th International Workshop on Asymptomatic Primary Hyperparathyroidism has a list. Osteoporosis or asymptomatic vertebral compression fractures, for example. We know if you fix the primary hyperparathyroidism with surgery, we can stabilize or improve bone mineral density and may decrease fracture risk. Other things, if you have high calcium in your urine or decreased GFR or incidentally noted but asymptomatic kidney stones, we know that if you have surgery, successful surgery, then it decreases the risk of stone formation moving forward. A lot of people, check their calcium yearly with their primary care doctor, and so you start noticing when the calcium is slowly climbing and is mildly elevated. But if your calcium is above 1 milligram per deciliter above the normal range, so higher calcium levels, you're more likely to be a patient who's going to develop a problem. We think about age, so age less than 50, right? You have many decades left to develop a problem related to primary hyperparathyroidism. At the end of the day, number one, you need to make sure that you have the right diagnosis. One other thing to remember is that in a small group of patients with mild hypercalcemia, mildly elevated parathyroid hormone, you can have the benign familial hypocalciuric hypercalcemia. And that's something we don't treat with surgery. The standard for a long time was if you're taking a patient to surgery for primary hyperparathyroidism, you're going to go in and look for all 4 glands. Some have 5, but most have 4. And then you decide based on how they look which ones you're going to take out. 80 to 85% of patients will only have one of the 4 glands that's a problem. With the onset of rapid PTH assays intraoperatively and more refined imaging options nowadays for preoperative imaging, a lot of surgeons have shifted away from always doing bilateral exploration, and now they're performing more focused or targeted surgery. You're limiting surgical complications, you're limiting operative time, but also offering patients similar cure rates. The problem is we don't know for sure up front if a patient's going to fall into that bigger bucket of just one gland being the problem, or if they have a double adenoma or multi-gland disease. There are 3 imaging studies we typically will choose from. One's an ultrasound. There's also a nuclear medicine study or a sestamibi scan, often paired with a SPECT CT that looks for over-functioning glands. There's a 3rd study, the 4D CT scan. That 4D component is looking at timing of the contrast washout. Once you have those imaging studies and you've talked with the patient, you've localized to one particular gland, that's often where you'll start during surgery. We have intraoperative PTH that we can check to make sure that you're biochemically confirming you've fixed the problem. And if the parathyroid hormone drops appropriately in the right, appropriately selected patients, you can finish surgery there and you're not introducing scar anywhere else around the thyroid. You don't have to go to the other side. Again, you're trying to decrease complication rates and get the patient off the table and out of the operating room. Imaging is not perfect, and there are times when you think you have the problem. Either imaging is localized to a gland or it hasn't localized. You've taken a parathyroid out and the PTH doesn't drop like you want it to, or it drops initially and then comes back up. Now you have to go look at the other glands. Patients who might localize on one imaging modality or even on both can have multi-gland disease that imaging doesn't pick up. So we use that PTH assay to help us to decide how much surgery do we need to do. There are other patient factors that make surgery harder, right? Patient habitus, if they've had neck surgery before and there's scar in the surgical field. If you have inflammatory disease of the thyroid, for example, you're at risk for kind of a bloodied field, obscured field. It's harder to see what you need to see. There are times when there's an ectopic gland, that you may miss because it's down in the chest. So near-infrared autofluorescence technology really is about parathyroid localization during surgery. It's not really used as kind of a screening imaging modality. It's better understood in thyroid surgery, actually, where studies have shown that it can help reduce rates of temporary hypoparathyroidism after total thyroidectomy. It can increase rates of parathyroid gland identification during thyroidectomy and can actually decrease rates of accidental parathyroidectomy during thyroid surgery. There are two main types of autofluorescence localization technologies out there. One is camera-based and one is probe-based. And basically what they're doing is detecting the autofluorescence emitted from the parathyroid tissue in comparison to tissue around it, because we know parathyroid glands emit a higher level of autofluorescence under near-infrared light than surrounding tissues. Both the camera-based and the probe-based system have a limited depth of penetration, 2 to 3 millimeters. These technologies are not substitutes for surgeon experience and surgical anatomic knowledge. If their depth of penetration is so small, you really need to have an idea of where you're looking. They are most useful to confirm what the surgeon thinks may be parathyroid tissue. Some areas that people are investigating, can we use this technology as we're looking for the parathyroid glands to identify what's an abnormal gland versus a normal gland? We have found that when you use some of these systems, there is more heterogeneity in an abnormal gland in terms of autofluorescence signal than in a normal gland. We don't yet have ways to quantify that. It would be great if we could use that technology to help us to decide which is the most abnormal. I think it's a great teaching tool. You can help the residents, right, as they're trying to figure out what's parathyroid tissue, what's not. It can replace frozen sections. We don't have great studies yet to really prove this across the board, but a lot of surgeons will send a little piece for frozen section to confirm, is this parathyroid or not? Well, now we have tools where we can assess that much more quickly.